بسم الله الرحمن الرحيم. السلام عليكم وأهلا بكم وأتمنى أن تكونوا بخير. In our last lecture, we have dealt with a couple of sporozoan parasites, mainly Plasmodia species causing malaria. And we said 4 important species cause malaria, and these are Plasmodium falciparum, Plasmodium vivax, ovale, and malari, and there are other minor ones. Usually these parasites are transmitted by the bite of the female Anopheles mosquito. And of course, you know what are the presentation and symptoms of malaria. And of course, in the control, you need to treat people. You need, whenever possible, to control, to take protective measures, as well as to control or eliminate mosquitoes, although it may be, in many situations, not easy to eliminate mosquitoes. Another parasite which is important, especially in pregnancy, is Toxoplasma gondii, and usually this parasite lives in various animals and human being, and usually infection is by ingestion of the infective or mature, what we call sporulated oocyst, and usually the cat plays an important role in the life cycle because sexual multiplication of the parasite Toxoplasma takes place in the cats. I think this is, we said, it causes many problems, especially in pregnancies. And we said due to the great association between the pets and the owners in the West, usually the seropositivity, at least showing infection, increases with age in the Western countries, while here from our observation in the Green Mountain of Dhofar, and with a little bit of a small survey, that the seropositivity varies from 10 to 60%, but severe cases are very rare, if any, in Oman. We said there is another smaller parasite causing interstitial pneumonia, and usually it's not easy to see this parasite unless you use a certain stain, which is known as silver stain. Well, that will end our coverage or overview of the protozoa, and we're going to start the big, or what we call multicellular parasites. These are known as helminthes or worms, and usually they are very variable in size, maybe just from 2 to 3 millimeters to up to 10 meters in case of 1 to 10 meters in case of cystodes, and in nematodes could be from a few millimeters up to 1 long foot parasites like Ascaris. So these multicellular parasites or helminthes could easily be divided into 3 main groups, and these are the nematodes. We'll speak about their characteristic precisely, the cystodes, which are called tapeworms, and the trematodes, which are called the fluke. As I said, there is another group known as Acanthocephala, but it is a minor group with only 4 species, which were rarely identified from more few cases of Acanthocephala infection were reported. So we are not covering them at all. Nematodes or nematohelminthes or roundworms, usually these are rounded, elongated, non-segmented worms. The body is somewhat cylindrical, and the nematodes have a complete digestive system. That is starting with the mouth, going through a sort of esophagus, which could be simple esophagus, just muscular, or it could be divided into muscular and glandular portion, then leading into a long tubular intestine, which end up towards the, or at the posterior end, at the anal opening. So they have complete digestive system. In the other groups, for example, in the cystodes, these are highly adapted parasites, and they have completely lost the digestive system. But the whole body tegument is capable of taking it of taking in nutrients. So you find a group of parasites with complete digestive system, and you find another one which has completely lost the digestive system. Members of the flukes or nematodes, they have a sort of simplified digestive systems. And for example, starting with the mouse, going through a sort of pharynx and then into the intestinal ceca. The intestinal ceca could be uh, long or short, and sometimes they can anastomose. It is almost closed. So the mouse in such parasite is usually used both as mouth and anus. The nematodes include free and parasitic species, and it is containing numerous species. It is estimated that about 80,000 species are parasites in the various vertebrates. So it is a big group. Male nematodes are usually smaller than the females, and they are characterized by having curved posterior ends. Maybe the females are larger because they usually produce numerous number of eggs. They are very variable in size. So the species parasitic in man, they could be as small as 2 millimeters in length, which is Trongloids styrocoralis, to more than 1 meter, like Dracunculus medinensis, or what we call the Medina worm. I have to say, many nematodes infect man, and a couple of them, they cause infection when we ingest their embryonated eggs, that is, mature developed egg, where there is a small larva or small larval nematode in the egg. So ingestion of embryonated eggs can cause infection by species like Enterobius vermicularis, what we call the pinworm, like Ascaris lumbricoides, which is known as a giant round worm, which could be up to 1 foot long, and also by Trichuris trichura, which is a whipworm, and this is about just 5 or 6 centimeter in length. Another group of medical importance, or another group of nematodes, can cause infection by the penetration of the larvae, and these are hookworms. Two important species of hookworms, Ankylostoma duodenale and Necator americanus. Their larvae can penetrate our skin, and we'll speak about them in more detail later. And the smallest nematode, which is infecting man, that is Trongloids, also causes infection by the penetration of the larvae. A third group, they can cause infection when we ingest undercooked meat. People who eat, for example, pork, undercooked or raw pork, they could be infected with Trichinella spiralis. Another group, for example, people who drink water containing cyclops or some crustaceans, they may be infected with the Medina worm, which is known as Dracunculus medinensis. So simply, there is a large number, I would say, of nematodes that can cause infection, and an infection is by different routes or ways. Our example here is Enterobius vermicularis, which is known as the pinworm. And usually we call it pinworm because if you look to the diagram, the female is almost elongated. At the upper right side, it is the anterior end, and towards the lower left side is the tail, which is almost sharp, ending sharply like a pen. So that's why the name is pinworm. If you look to the male, it is comparatively smaller, and usually the tail is curved. They have characteristic eggs. Usually the egg is somewhat flat on one side and somewhat concave on the other side. And usually the eggs they develop after laying, they could be developing an embryo within 4 to 6 hours. So this parasite is usually very easily transmitted, as you will see later. Because in enterobiasis, infection could be by ingestion or inhalation of eggs, that is embryonated eggs, eggs with embryos. And you can get those eggs from contaminated hands, from dust, from bedding, or also could be by autoinfection. Because of the easiness and different ways of transmission, this parasite is cosmopolitan, but common in children. This parasite, for example, when it is in any house, it is easily transmitted to the members of the family. And that's why it is advisable, if somebody is infected, it may be advisable that the other members in the family, they should take treatment. The good news, anyhow, it is not causing serious infections. The parasite usually inhabit the large intestine, mainly cecum and colon. And that's why at night, the female worms migrate to the anal opening and they lay eggs on the preanal skin. Those eggs, after laying, they can develop an embryo in a couple of hours, and the embryos can crawl back through the anal opening, causing autoinfection. So infection is by inhalation of eggs because they are easily blown in the air, and it could be also by ingestion of eggs in contaminated food or water, as well as by autoinfection or self-infection. Pathology, many people, they could be asymptomatic. They are carrying the infection, but they don't show any symptoms. However, the infection can cause itching at night because of the migration of the female worms, and this may result in what is known as pleuritis ani. Due to the migration and the irritation, usually infected children, they have disturbed sleep, and they become nervous and irritable, and they suffer from irritability. They may not be eating well. So I think if a mother recognizes that her baby is not sleeping well, maybe either just in the morning she can try to look at the bottom of the child, and she may see a small, about 1 centimeter long, creamy, small nematodes, and these usually are the female Enterobius vermicularis. The parasite, of course, because of causing infection, it may cause ectopic infections. So in females, it may go through the vagina, and from there, it can result in a sort of vaginitis and maybe appendicitis and infection of the uterus and fallopian tubules, known as salpingitis. So these ectopic infections are rare. In many situations, children who are supposed to be stopping bedwetting at a certain age, if they are doing it, they may be suffering from pinworm infection. So it has been associated with bedwetting. And it was recognized that children who suffer from bedwetting, after treatment of enterobiasis, they stop this bedwetting. This infection, as we said, is cosmopolitan. It's only mainly causing irritability, disturbed sleep, etc., and just itching and pleuritis ani. It could be diagnosed because most of the eggs are laid at night at the preanal skin or preanal folds. Usually examination of stool may not be sensitive. So the best thing is by what is known as sellotape swab, which is known as Scotch tape or adhesive tape. So the mother in the morning can just have this adhesive tape, just push it over the preanal folds of her baby. They will pick the eggs, and of course, this tape could be put on a microscopic slide, and it will be more sensitive for examination than just examining stool. So precisely diagnosis is by Scotch tape or adhesive tape swab of the preanal region. Different medicines could be effective. Among them are mebendazole and albendazole, but there are other drugs. I want to keep it short and simple. It is advisable, as I said at the beginning, because of the easiness of transmission, to treat the whole family. Control is mainly a matter of hygiene, because children, for example, the infection is comparatively more prevalent among children because of their unhygienic behavior. So education and hygiene are essential for controlling high prevalence of pinworm infection. Another important parasite causing infection in man and causing infection by ingestion of embryonated eggs is Ascaris lumbricoides, which is known as the giant roundworms. The photograph here to your left, you have the long and comparatively thin with a curved posterior end. This is the male Ascaris. To your right is the comparatively bigger and stouter parasite, which is rounded or cylindrical, is the female. And in the middle, you see that there is almost a rope of intermingling Ascaris almost blocking the intestine. And this usually intestinal obstruction can happen in heavy infections because the worms are long and they can just intermingle together to form a solid rope which can block completely the intestine, which may sometimes necessitate operation. In the laboratory, they can see different forms of Ascaris egg. For example, the usual eggs which are seen are the one to your left, which is rounded with rough mammillated eggshell. The one to the right of that one, it is under a little bit of pressure in a test known as cat-to-cat technique. Usually the eggs are put under cellophane tape and causes some pressure and it clears up the parasite. To the right of that, you see there is almost an egg with a smooth eggshell. It lost the tough mammillated eggshell. This we call decorticated Ascaris eggs, eggs without the tough mammillated albuminous eggshell. The barrel-shaped egg is usually unfertilized. Okay, so sometimes if the egg is not fertilized, usually it assumes this barrel-shaped structure. We'll speak a little bit about the life cycle of Ascaris. As we said, infection is by ingestion of embryonated eggs. So usually in the intestine, the larvae or the embryo are released from the ingested eggs, and the larvae will penetrate the intestinal mucosa, and they migrate because they reach, for example, the hepatic portal vein. They go to the liver, and then to the heart, and then they reside and develop and molt in the lungs. After that, they are cuffed up the bronchi and the trachea, and of course they could be spitted out or swallowed into the intestine where they become mature in about 5 weeks. So this parasite is not only living in the intestine. We can say that it has a tissue migratory phase as well as an intestinal phase. The larval migration, of course, when it is in the liver, in the heart, in the lungs, it can cause, for example, sort of hepatitis if it is heavy infections, many larvae, and of course also in the lung, they can cause a certain type of pneumonia, as we'll see later in the pathology. So the pathology, what happens during the migratory phase when the larvae goes out of the intestine and makes this tissue through the liver to the heart, to the lung, etc. So may be accompanied, migratory phase may be accompanied by hepatitis, inflammation of the liver, pneumonitis, which is usually with cough, chest pain, and difficulty in breathing. And this pneumonitis is technically known as Lofral's pneumonia. Lofral's pneumonia. And it may be accompanied by some allergic symptoms and eosinophilia. I have to emphasize here or to point out in many tissue migrating infections, parasitic migrating infections, they may be associated with eosinophilia. So if there is high eosinophilia and the reason is not known, you may check for possible parasitic infections, and usually those parasites are supposed to be moving or living or invading tissues and organs, but not in the intestine. So precisely, high eosinophilia may be usually an indication of a tissue nematode infection. Then we come to the intestinal infection when the parasite is in the intestine. It depends mainly on the number and the size of those parasites. Large numbers may cause intestinal obstruction, as you have seen in the photograph, and because they feed on what we eat, they may cause malnutrition, particularly among people who is undernourished. Sometimes you have what is known as wandering worms. That is the worm. It is a large nematode. It moves out of the intestine. It goes crazy, and it can move, for example, to the pharynx. It can go to the eustachian tubules, so it can cause asphyxia, and it may go to the spleen, causing what is known as obstructive jaundice, and of course pancreatitis, and sometimes it just moves in the peritoneum, causing peritonitis. So wandering worm infections are there, but comparatively are fewer. Here, just to see that a child who has been treated and is passing out a bunch of large worms. And here you can see this child. The worms are coming out from his nostril as well as his mouth. So these are wandering worms. Diagnosis of scaries is by recovery of eggs in the stool. Of course, this is almost predominantly the main way of identifying intestinal parasite infections. You look for their cyst, their larvae, or eggs and trophozoite. So here, usually, you can see the eggs in the stool. But occasionally and incidentally, the larvae may be recovered in the sputum in some patient. Treatment, couple of medicines are available, like mebendazole and albendazole. So I just wanted to say, because we mentioned also mebendazole and albendazole in the treatment of the pinworm, Enterobius vermicularis. So mebendazole and albendazole are broad spectrum medicines for or against intestinal nematodes. Of course, control is proper hygiene. People, they should have, for example, washrooms and latrines so that the environment is not contaminated by the eggs which are passed in the stool, for example, of children and other people. So hygiene is very important. We come to another group which causes infection by the penetration of the larvae. Each one is a larva, and if we are talking about more than one, we call them larvae. And the important parasite causing infection by penetration of the larvae are what we call the hookworms and also Strongyloides styrocoralis. The important hookworms are Ankylostoma duodenale, which is comparatively larger than Nicetra americanus, as you can see here in the size. Just to give you an idea, I don't want you to know it by heart, but they're just about, in ankylostoma, it may be 1 centimeter or a little bit longer, and Nicetra americanus may be under a centimeter to 1 centimeter. Ankylostoma duodenale, in most of the textbooks, is known as the Old World hookworm, and Nicetra americanus is known as the New World hookworm. I think this naming is not very precise, because here, at least in Oman, in the Green Mountain of Dhofar, we recovered Nicetra americanus. We even dewormed about 25 infected people from 4 localities in the Green Mountain of Dhofar, and all of the worms recovered were identified as Nicetra americanus. So maybe just Nicetra americanus was first identified in America, but the parasite is not necessarily limited only to the New World. It could be in the Old World as well. Usually, they are very popular infections. They are infecting about 900 million people, and the parasite inhabit the duodenum, so they are found in the small intestine. Why do we call them hookworms? If you look to the photo on your right, there is 2 pairs of protruding hooks or teeth-like structures. So that's why the name hookworms, worms with hook. So the name is very typical for Ankylostoma duodenale. In Necator, there is almost just chitinized structures on the mouth cavity, and the hooks as well as these chitinized plates are capable of attaching, grasping, for example, villi, and they can cut them to suck blood. If you look to the picture to your left, the upper one is the female, and the under one is the male. And here, the male is unlike the other species. It doesn't have curved tail. It has a sort of an inflated end known as copulatory bursa. It's a sort of a small umbrella. Some chitinized structures joined by thin membrane. And the function of it, people, they say usually during copulation, the male grasp or hold the female by this sort of copulatory bursa or umbrella. There is other minor hookworms, but usually they are animal parasite, but occasionally they can infect a human being. The larvae penetrate human skin, but they don't become adult parasite. They just cause migratory infection, known as visceral migration and cutaneous migration. This is, for those who have not been to Zofar, this is Wadi Darbat during the Kharif. It is a very beautiful green and lavish greenness and nice weather. And in many weeks or days in Zofar, for those from Zofar, you can hardly see a strong shining sun. It is almost cloudy, and it may be misty, so there is no, and humidity is just I would say around the mid-20s, which is very favorable condition for the survival of the larvae of hookworms. So in a community, for example, among the Jabali people, especially in the old days, usually they don't have latrines, and children, they just defecate around their settlement. The eggs will hatch, and the larvae come out of the egg, and they can just climb, for example, on the grass. And of course, there is a little bit of water, and because it is almost humid and there is dew, so this humid and mild temperature is very appropriate for the longevity of the life of the larval stages. So, for example, next morning the child is going back for frequent where he defecates or passes stool, and he can kick the grass, so the larvae dropped on his feet and they can penetrate. So here, infection is by penetration of the larvae. So they migrate like the migratory phase of Ascaris. So they go through the liver to the heart, they develop in the lung, and then they are coughed up and swallowed in the intestine. Just to follow it, this sketch life cycle. Usually the eggs are passed, and they have to give a larva. That larva is known as rhabditiform larva. It is a free living larva. It just feeds on the decomposing fecal material, and it molts, that is, it grows, it changes the old skin as it increases in size, and it transforms into the infective stage known as filariform larva. If the filariform larva comes in contact with the human skin, it penetrates, and then it migrates like Ascaris larva, and it goes, as I said, to the liver, to the heart, to the lung, and then ingested or spitted out, and it reaches maturity within 5 to 6 weeks. The parasite generally can live for 6 to 8 years, and in Encrostoma duodenale larvae, it is known that they may become dormant for long years. This has been noticed or identified when some patients who move from endemic areas and they have been treated for an infection, and after a couple of years, then they have the infection again. So it means the larvae have been dormant, and for whatever reason, maybe drop in immunity, they were activated again to be adult parasite. This behavior of dormancy is not identified in case of Necator americana infections. Although we said the hookworm can live for 6 to 8 years, but in many situations, it lives or eliminated in less than that period. In the intestine, the adult worms using their cutting plates and hooks. They attach to the intestinal mucosa and start sucking blood. These parasites, they have the habit of abandoning their site to have a new attachment site. So in this behavior, after sucking blood, they leave to take a new hold and leaving the lesions bleeding out. And this results in blood loss and in an anemia, which is known as hypochromic microcytic anemia. So the penetration, when you speak about the pathology, the penetration of the larvae can result in dermatitis or simply just itching. Depending on the intensity of infection, they may cause pneumonia, they may cause hepatitis, and the well-known complication is what we call hypochromic microcytic anemia, which is due to iron loss. Of course, in heavy infections, children may be suffering from retarded growth. Diagnosis is by seeing the ova in the stool, and for the treatment, of course, oral iron supplement, albendazole and mebendazole may be good. I have to say, hookworm infection in the Green Mountain of Zafar used to be a public health problem because in some areas could be almost, we did a little bit of survey in one of the localities, it was up to about 70% of the school children were infected. However, the Minister of Health launched a control program, and after 4 years of mass chemotherapy in those areas, that is, they give medication before the transmission season, that is just to do in people, the percentage when it started in that locality, it was about 40% in the rural areas. So it drops from 40% to 6% in the rural areas. And after the first year, it drops to 1% in the big cities. So control could be by treatment of infected people, sanitation, that is development or building of latrines and not open air defecation, wearing of shoes so that you avoid penetration of the larvae is good, and avoid using human excreta as fertilizers because the human excreta is containing the eggs and sequentially it contains the larvae that can cause infection. Okay, we have a group of parasites. They are known as tissue nematodes or filarial worms, and they are not causing infection by ingestion of eggs, not by penetration of the larvae, not by ingestion of meat like pork containing the cystic larvae, and not by drinking water, but by the activity or of their insect vector. So we have a group which are, all of them, the life cycle is typical because all of them, they need insects as vectors, and the life cycle is between the vector and the human beings. So we have about 8 species of worms known as filarial worms, all of them characterized of being creamy in color, maybe variable in size. The males are usually small, maybe 2 centimeters, but the female could be up to 50 centimeters long, and all of them are thin, white, or creamy in color, and each one needs an insect for transmission, and usually they don't give eggs. They give almost moving larval stage called microflaria. Collectively, they are known as microflari. So females give birth to larvae, and these larvae are called microflari. What are those important species of filarial worms? This is, for example, a microflaria of one species known as Washereria bancrofti. And usually, if you see the arrow, there is a small, almost transparent folding here. This is known as the sheath. Usually, the sheath could be SHEATH. It is the same membrane surrounding the egg. And usually, the larva keeps it, and it is only noticeable at the extremities, at the anterior end as well as the posterior end. The microflari, or the major filarial worms, and their vectors, Washereria bancrofti, is transmitted by Culex, but by many other species. Brugia malay by Culex and any other species. There is Brugia taimori. So precisely, I would like to say the Bancroftian filariasis or filarial worm infections causing enlargement, for example, of the legs, hydrocele, and other complications. They are transmitted by various species of mosquitoes. In actuality, different species belonging to 4 genera of mosquitoes, they can cause infection. So we can say, for example, Wuchereria bancrofti is transmitted by more than 70 species of mosquitoes. And those mosquitoes belong to the genus Culex, Anopheles, Mansonia, etc. But the most important insect or mosquito transmitting Wuchereria bancrofti and Brugia is known as Culex fasciatus. So Culex fasciatus is the most important vector of filarial worms, Wuchereria, Brugia malay, and Brugia taimori. This, at least Brugia taimori and bancrofti and malay, they both or all the three species live in the lymphatic tissues, and they can cause what is known as lymphatic filariasis or Bancroftian filariasis. It is manifested in chronic infections in what is known as elephantiasis, people with big, for example, distended legs. You will see the photograph later. Another filarial worm which is very important and it is causing a very dreadful infection, which is infection of the eye, is known as Onchocerca volvulus, and it is transmitted by what is known as black fly simulium. The species important is known as Simulium damnosum. So Onchocerca volvulus causing what is known as river blindness, because the parasite lives in the skin and it causes onchocerciasis or river blindness. Usually it lives in nodular protrusions known as onchocercomas, and usually those sarcomas or nodules, they are found in bony areas, and if they are in the head, so they are not far away from the eye, and the larvae, which is the microfilary, can go and it can cause eye problem or vision problems. Let us have a little bit of idea here about lymphatic filariasis. You could see here at least 3 different patients who are showing different manifestations of elephantiasis. I just wanted to say about 120 million people are actually infected, and about 1.2 billion people in 83 countries are at risk of infection because they are living in Bancroftian or in lymphatic filariasis endemic areas. Usually people who develop these manifestations to this extent, they need to live in the endemic area for quite a long time, and there is almost repeated inoculation of the parasite by the vectors, by the mosquito. So diagnosis of the infection is by seeing the microfilary in night blood. This is usually in Wuchereria bancrofti and in Brugia species, or skin sniffs in Onchocerca. Why, for example, night blood in case of Wuchereria? Some parasites show a phenomenon known as periodism. That is, in certain period of the day, they are found in the peripheral circulation, but the same patient who is showing the parasite at night in the peripheral circulation, if you take blood during the day, you will not find the parasite. And many people, they believe that there is synchronization of this behavior of the parasite with the activity of their host. So Wuchereria bancrofti, Brugia malay, Brugia taimori are transmitted by the bite of mosquitoes, and mosquitoes usually are night feeders. So it is advisable, if you are suspicious that the patient is suffering from Bancroftian filariasis, is to take blood advisably just before midnight or anytime after 8 p.m. Onchocerca volvulus infection, usually there is nodules, and you have to take snips from the skin, and usually it may contain the parasite. Treatment is by diethylcarbamazine and ivermectin. Control, of course, they are transmitted by insects. If we can control the insect and avoid being bitten by those vectors, it will be good. This brings me to the end of this lecture. I have tried to give very basic and essential information. I didn't go into the details because at this stage it is just an overview, our introductory part of the parasite. Thank you. Stay safe and well. See you next time. Bye.